Good afternoon, everybody. Thank you for joining the DSI Roadshow for Health IT Developers webinar. My name is Josh Shapiro with Capital Consulting Corporation, and I'll be assisting today with the logistical support. We have enabled the Q&A pod, so you can ask your questions by clicking that Q&A button at the bottom of the screen. You can also ask your questions verbally by clicking the raise hand function under the reactions, and I'll go ahead and unmute your line so you're able to ask the question during the Q&A session. Additionally, we ask that you select the speaker view option, which is located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share the information. If you have any need for technical assistance, please use the chat to type in your question to one of the techs, and we will respond to you and help you out. Finally, please be aware that today's session is being recorded. Closed caption is also available by clicking the CC icon at the bottom of your screen. And now I'll go ahead and turn it over to Jeff Smith, who will kick off today's events.
All right. Well, thank you very much, Josh. And thank you all out in internet land for joining us in this mini-series, which we're dubbing the DSI Summertime Roadshow. Over the course of this presentation, we are going to do a deep dive into the requirements for Health IT modules that are certified to 45 CFR 170.315B11. This is, of course, the decision support interventions certification criterion. This is new to the program, and it is required that developers who are certifying modules to this criterion do so by the end of the year in order to maintain their compliance with the base EHR certification definition, because the current decision support criterion at 170.315A9 is due to expire at the end of this year, and B11 is going to join the other criteria in the base EHR definition. We've, generally speaking, developers who want to maintain modules that are certified to the base need to update their modules to B11 by the end of this year. So we thought it would be an opportune time to walk developers and other interested parties through the B11 criterion requirements, as well as associated requirements around maintenance of certification requirements and other kind of wraparound requirements like safety enhanced design. We also, over the course of the last several months, have received numerous inquiries and other requests for clarification, and we're going to highlight some that are included in the DSI resource guide, as well as others that are up on our B11 CCG. And of course, we've got links to all of these resources. So without further delay, I'd like to introduce my colleague, Nikki Hayes, who is going to take you through this presentation and highlight some of our resources. And then we will be happy to take questions at the end. And we would highly encourage that if you've got questions that you'd like to discuss, we've got the Q&A function engaged, so please use the Q&A function. We'll try and answer questions in real time, as well as maybe pull some out at the end. And if you've so please use that function during the course of the presentation as questions arise. Okay, with that, I'll turn things over to Nikki.
Hi, good afternoon, everyone. Thank you, Jeff, for that awesome introduction. My name is Nikki Hayes. I am a public health analyst on the Certification and Testing Division. Currently, I work with Jeff and the subject matter expert on DSI. Today is the first of our summertime roadshow series. So we're going to dive a little deeper into DSI. So let's go with the next slide, please. This is just our disclaimer. The materials contained in this presentation are based on the provisions contained in 45 CFR parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that other federal, state, and local laws may apply. And this communication is produced and disseminated at U.S. taxpayer expense. Next slide, please. And I'm just going to turn my video off because I know we've got a lot of data on our screen there. Okay. This is our agenda for today. We're going to go over definitions and concepts and some of the required capabilities of B11, along with B11 timelines. And hopefully at the end, we'll have time for question and answers. All right, next slide, please. Perfect. This slide's just highlighting some of the resources that we have produced since the rule dropped. In May, we developed a DSI resource guide. It's a version 1.0. We are currently working on edits to this particular document, but this sort of distills the proposed rule down and the final preamble into some plain language explanations. We've got clarifications within this resource guide. It's also a walkthrough of the requirements of the B11 criterion. You'll see there the last bullet point. That is a link to the resource guide. It's also on our website under program resources. Next slide, please. And an additional resource we've developed is the 9 key functionalities and requirements of the new B11 DSI criterion. This we published on our website, I believe in June of this year, highlighting 9 key functionalities for certified health IT developers. It includes tips and resources. Just an example of some of the tips that we have is DSI requires to enable a user to provide electronic feedback data for evidence-based DSIs, including at a minimum the intervention, action taken, user feedback provided if applicable, the user, the date, and the location. And the tip we have is we note that action taken by a user likely will be specific to the intended use of the evidence-based DSI. Actions could include whether the user viewed, accepted, ignored, overrode the DSI in some way. Again, those are some 9 helpful tips within this new resource that we've developed. Next slide, please. All right, and next slide. We're going to go into some key definitions and concepts. You will likely be familiar, obviously, with the definition of predictive decision support interventions. So just a little refresher here. The finalized definition for predictive decision support interventions, or predictive DSI, is technology that supports decision-making based on algorithms or models that derive relationships from training data and then produces an output that results in prediction, classification, recommendation, evaluation, or analysis. The scope of the definition is broad. It is use case inclusive. It is risk independent and is developer agnostic. I think it's important to understand the reasons that we did this. We wanted to cast a wide net. There are many technologies out there that may be considered a predictive DSI, but not all predictive DSI technologies are going to be subject to the requirements at B11. The definition is broad, however, there is a more narrow construction in terms of which among those predictive DSIs will be subject to the requirements in the rule. The definition applies equally despite the use case and despite the level of risk. Next slide, please. So here we're going to talk about a few key concepts. Additionally, we're going to talk, this first bullet point here is evidence-based DSIs. They are rules-based rather than based on relationships learned in data, and often are based on consensus clinical guidelines. For example, a decision support rule that recommends a follow-up appointment within 12 weeks, according to the United States Preventative Services Task Force, recommendations would be considered an evidence-based DSI under ONC's regulations. Only DSIs that are actively presented to users in clinical workflow to enhance, inform, or influence decision-making related to care a patient receives and that do not meet the definition for predictive decision support interventions. That's at section 170.102. Actively presents stands in contrast to decision support that initiates an action without a user's knowledge or occurs outside a user's normal workflow. Some other concepts are the source attributes. Those are categories of technical performance and quality information related to how both evidence-based as well as predictive DSIs were designed, developed, and tested and should be used. Another concept throughout the regulation is phase. It's a conceptual model for decision support intervention quality. Each source attribute and risk management requirement contributes to a better understanding of whether a predictive DSI is fair, appropriate, valid, effective, and safe. We also refer to that as phase. Additionally, another concept is the intervention risk management, or IRM practices. It's a set of activities used to analyze and mitigate different kinds of risks associated with predictive decision support interventions. IRM practices should include policies and controls for governance and data management related to predictive DSIs. Next slide, please. This slide, again, key concepts are continued. The supplied by configuration nexus. This is a term you're going to hear quite a bit about throughout this presentation. The supplied by configuration nexus. This is where we have received quite a few questions in our JIRA portal. At 45 CFR 170.315B11, the regulation text states supplied by the Health IT developer as part of its Health IT module. Certified Health IT developers can supply evidence-based and predictive DSIs they create themselves, and they can supply DSIs created by other parties. Supplied by means that the certified Health IT developer takes stewardship and accountability for that specific evidence-based or predictive DSI within its Health IT module. Another concept we like to hone in on is the as part of its Health IT module. This means that the developer of certified Health IT has explicitly offered or provided its customer the technical capability to use or support a predictive decision support intervention, regardless of whether the PDSI was developed by the developer of certified Health IT or by other parties. Supplied DSIs can comprise clinical, administrative, operational, and use cases. Next slide, please. So here, next we're going to go over some of the required capabilities of B11. Next slide. Thank you. Decision support configuration. So here, Health IT modules certified to B11 must enable the following. They must enable a limited set of identified users to configure both evidence-based and predictive DSIs based on the user's role. Must enable interventions based on reconciliation of patient meds, allergies, and tolerance, and problems as part of transition of care or referral summary. And must enable users to provide electronic feedback data for evidence-based DSIs. Some examples of that feedback data are the intervention, the action taken, the user, the date, the location. The module must also make feedback data available to a limited set of identified users for export in a computable format. Next slide, please. So some clarifications on feedback loops. Only evidence-based DSIs actively presented to users in a clinical workflow to enhance, inform, or influence decision-making related to patient care, related to the patient care, related to the care patient receives must be supported by feedback loop functionality. The certification requirements do not specify when or how feedback should be gathered. Requirements are intended to be flexible to enable a user to provide feedback in a manner appropriate to their workflow. Nothing in the program requires users to actually provide electronic feedback. Developers of Health IT modules certified to B11 must allow a specific group of users, and that specific group is determined by the user organization, must allow those specific users to access and export feedback data in a computable format. The developer is not required to export to all users. Instead, the option to export feedback data must be available to a specific group of users identified by the customer. Next slide, please. And just some additional clarifications on feedback loops. Again, these are some of these are from questions we have received through our JIRA portal. It must enable a user to provide electronic feedback data for evidence-based DSIs selected via a capability in B11.3a, numerat 3a, including drug, and drug allergy contraindication checking. User feedback must be included as part of the evidence-based DSI export of metadata, if applicable. Therefore, developers must provide the metadata when user feedback is provided, as well as when user feedback is not provided. Next slide, please. So DSI selection. Developers must enable a limited set of identified users to select or activate evidence-based and predictive DSIs. The program did not list out the evidence-based or predictive DSI use cases that developers must support. Instead, the program establishes a scope of DSIs that must be supported based on data elements found in US CDI. Evidence-based DSIs within the program that must be supported include those that use any of the following US CDI-based data elements. And you see those listed here: problems, meds, allergies, intolerances, etc. Next, oh, I'm sorry. Scrolling down here. Evidence-based DSIs that do not use any of those data elements do not need to be supported and aren't subject to other B11 requirements, such as feedback loop functionality. Predictive DSIs within the scope of the program must be supported and include those that use any US CDI data element. Next slide, please. So these are additional clarifications on selection. DSI selection, we did not specify a standardized configuration to enable the selection of evidence-based and predictive DSIs. Developers must support the ability for customers to select predictive DSIs, whether those were self-developed by the customer or by other parties. Evidence-based DSIs that include any demographic data element in section 170.315A5I must be supported. These are different in scope and may require the use of different vocabulary standards than US CDI data elements listed under the patient demographics information data class versions of these data concepts. The modules must support evidence-based DSIs that use data concepts at section 170.315A5I and should adhere to standards and requirements in that same section. In our resource guide, you will find Appendix A, which has the scope of US CDI-based data elements that must be supported for use in evidence-based DSIs. Next slide, please. So source attribute support. Health IT modules certified to B11 must support 13 source attribute fields for evidence-based DSIs and 31 source attribute fields for predictive DSIs. The developer is not responsible for the content of the source attributes fields. However, they must make space or support source attribute fields for evidence-based and predictive DSIs. Again, this goes back to the supplied by concept. A developer is responsible for the content of the DSI if the DSI is supplied by that developer of certified health IT. Developers should work with their customers to determine the best format and structure of source attribute information and format. Next slide, please. So this is the 13 source attributes for evidence-based DSIs. Going to look a little further here. Those 4 listed on the left, those are consistent with the A9 CDS criterion. We have added an additional 9 source attributes. That's 5 through 13 on the right. Those are related to the specific data. This allows users to know when this information is being used in the DSI, and the user can make the determination whether the data elements are appropriate for use in the DSI tool. This is back to the concept of transparency. A user should have access to the data information within the 13 source attributes. Next slide, please. And that's just a little animation that showed that the 4 on the left were already there from the CDS criteria, and the 5 through 13 are the additional from B11. Next slide. All right, additional clarifications for developer-supplied evidence-based DSI source attributes. When a DSI is not based on published clinical guideline, but local needs, the bibliographic citation and the developer of the intervention may be the same. When the information is only available through published literature, developers may indicate source attribute information is not available and that it cannot be replicated. For the source attributes in 5 through 13, use of the data element is required to be disclosed. Developers are not required to indicate when one of these data elements is not used, however. The program requires developers to indicate when an evidence-based DSI uses patient demographic, social determinants of health, and health status assessment data elements in the 5 through 13. This is consistent with the dates established in section 170.213. Health IT modules must indicate when USCDI version 1 data elements are used in evidence-based DSIs, and that they must do this up to and including December 31st of 2025. Beginning January 1st of 2026, Health IT modules must indicate when USCDI version 3 data elements are being used. Next slide, please. This slide is showing the 9 predictive DSI source attribute categories. We sort of look at these in 3 sections. The first section is 1 through 3. This is what the intervention does, how it should be used, and how it should not be used. The second row, 4 through 6, this is how the intervention was developed, including input features, processes used to ensure fairness and external validation of the model, if any. And then that last section, 7 through 9, this is how it performed, quantitative measures, how it's being maintained, and how it's being updated. Next slide, please. And I know there's a lot of text on this, this particular slide, but this is the 31 predictive DSI source attributes. Here we emphasize source attributes information that are most frequently included in existing reporting guidelines. These are meaningful and interpretable in the context of health IT users and developers focused on health equity and fairness. The source attributes may be useful in identifying issues of bias, and they are intended to show that the model would perform effectively outside of the specific context in which it was developed. We analyzed and drew from more than a dozen widely accepted and used reporting guidelines used by researchers and developers to demonstrate the validity of algorithms in peer-reviewed literature. We believe that much of the same information required for publication by the New England Journal of Medicine or the Journal of American Medical Association should be routinely and consistently available for user review to improve the trustworthiness of predictive DSIs. Within these 9 categories of source attributes, we've specified 31 types of information listed here. Again, I know this is a lot of information, but we can sort of look at number 2. This is the purpose of the intervention, for example. We've included 4 specific source attributes, which would be the intended use of the intervention, the intended patient population, intended user, and intended decision-making role. And each of these items that we described in the proposed rule as those that should be included in reporting these source attributes. The aim is to be more specific and narrower in the types of information that are required to be reported. The goal of the source attribute list is to establish a consistent industry-wide foundation upon which others may standardize or customize. These also align with the existing reference material from NIST, the White House Blueprint for AI Bill of Rights, and White House executive orders. Next slide. Perfect. So you'll notice this is basically the same, the previous slide. We just have some items that have been highlighted in yellow, as well as you'll notice the asterisks at the headings. For those with the asterisks and highlighted in yellow, they are the source attributes that may not be within the control of developers. Notably, those with the asterisk or highlights, yellow highlights, a developer may indicate as unavailable or leave blank. Now, developers are not required to externally validate, but we think external validation is a good idea. Therefore, we have the fields, but those with asterisks are not required. The asterisk and the yellow highlights. The source attributes with asterisks and yellow highlights should be well within the developer's ability to obtain. I'm sorry, I misspoke. The source attributes without the yellow or the asterisk should be well within the developer's ability to obtain. The absence of this information should be a signal, and we also have requirements for those fields to be supported. Next slide, please. And again, next slide. Perfect, thank you. Some additional clarifications on developer supplied predictive DSI source attributes. While the program identified defined input fields for predictive DSI source attributes, it does not establish requirements for specific measures or thresholds for content related to those categories. The program has not established requirements for specific measures of validity or fairness. Developers may indicate that the relevant information for specific source attributes is not available nor recreatable. One of the examples is in the predictive DSI that use models provided through peer-reviewed literature, such as the EGFR, may not have access to the training data that would allow a developer to provide the description of demographic representativeness. In these scenarios, developers may indicate the information is not available and cannot be replicated. And that last bullet point is just another example of that. Next slide, please. So here's a little animation slide, sort of honing in on the supplied by concept. So when is the developer responsible for source attributes? NES is an electronic health record. And NES has developed a hypertensive predictive model. And NES HR has Zelda's hypertensive predictive model. Perfect. And those two hypertensive predictive models, they are considered predictive DSIs, authored, developed, or supplied by the health IT developer, and they are subject to the ONC B11 requirements. And next animate, there we go. There's also Konami's contraindications model. This is made by a third party for NES EHR. And this does not, even though it is a predictive DSI, it is not one that is subject to the ONC requirements for B11. Next slide, please. Again, still on the supplied by, these are examples of supplied by configurations. Supplied by the Health IT developer as part of its Health IT module would likely include if the developer offers to its customers the purchase or use of a hypertension model as part of its Health IT module, pardon me. If the developer includes a publicly available predictive model similar to LACE Plus or Apache 4 as part of its certified Health IT product. The developer incorporates any other party's LLM or large language model or other generative AI that meets the definition of predictive DSI and is part of what the developer offers its customers. Again, supplied by would not likely include apps available through a certified Health IT developer's app store. Next slide, please. Again, staying on this supplied by concept, as well as as part of its Health IT module. If a developer is taken on stewardship and accountability for the predictive DSI for the purposes of its Health IT module, as part of its Health IT module means that the developer explicitly offered or provided its customers the technical capability to use or support a predictive DSI, regardless of whether it was developed by the certified developer or by an other party. As part of its Health IT module is any supplied DSI that are part of the B11 certified Chapel listed product. If a developer supplies a predictive DSI as part of a product that is B11 certified, the developer must include source attributes and other requirements for that predictive DSI. Next slide, please. So now we're moving on to the concept of access and modification of source attribute information. Program has established 4 capabilities that the Health IT modules must support. Health IT modules must enable a limited set of identified users to access complete and up-to-date plain language description of source attributes. That limited set of users must be able to record source attribute information. The limited set of users must be able to change source attribute information. And the Health IT module must indicate when source attribute information is not available for some source attributes related to external validation, local testing for validity and fairness, and continued assessments of validity and fairness. Developers are responsible for updating information related to these source attributes if it is generated or becomes available with that developer's knowledge. Next slide, please. And here's more, some additional clarifications on the access and modification concept. A subsidiary of a developer that develops a predictive DSI is the same as if the subsidiary were the certified Health IT developer and therefore subject to the same requirements as a predictive DSI supplied by the developer. Developers must provide the functionality to enable access and modification to source attributes, but are not responsible for the content that may be recorded, changed, or accessed by those users. They also must enable users the capability to populate source attributes for predictive DSIs that are self-developed by customers, as well as the capability to populate source attributes for predictive DSIs developed by other parties. Developers are not responsible, however, for the accuracy or use of source attribute information that is modified by their users. Rather, developers are required to have Health IT modules that support the capability for their users to author or revise source attribute information. Next slide, please. And this slide, this is another one where we've had a few juror questions, some clarification on the complete and up-to-date plain language descriptions of source attribute information. The program does not prescribe how source attribute information is made accessible to the user, nor do we prescribe a minimum level of context at this time. For example, we do not require that a source attribute indicating the use of social determinants of health must describe how the data element is used as part of the evidence-based DSI. Instead, we require a module to enable a user to review whether a social determinant of health data element is used as part of the evidence-based DSI, and which social determinant of health data element is used as part of the evidence-based DSI. When multiple data concepts of social determinants of health occur, and there's an indication of yes or no, this would be considered insufficient. This may also be the case for other source attributes and related data concepts listed at section 170.315 B11.4. Really, the big takeaway is, particularly as it relates to plain language, complete and up-to-date plain language, we encourage developers to consider what information would be most useful for users to determine if a DSI is fair, appropriate, valid, effective, and safe, the phase concept. And we encourage as much plain language as possible to make the information most easily understandable and useful. Next slide, please. This is a clarification on limited set of identified users with access and modification. We have had, again, we've had several questions on this concept of limited set of identified users. With this concept, it allows restriction of certain functionalities to a smaller group of users that are specifically identified and granted the necessary privileges to use the capabilities. So not necessarily everyone that has access and uses the electronic health record. It can be restricted to that limited set of identified users. Developers of certified health IT and their customers are best positioned to jointly decide the scope of users. The certified health IT developer is best positioned to determine the mechanism to enable the limited set of identified users to select or activate the electronic DSIs. Next slide, please. This is organizational transparency on risk management of predictive DSIs. Intervention risk management practices must be applied for each predictive DSI supplied by the health IT developer as part of its health IT module. Predictive DSIs must be subject to an analysis of potential risks and adverse impacts. They're subject to practices to mitigate identified risks. Those policies should also, the risk management should also include policies and implemented controls for governance, including how data are acquired, managed, and used. The final rule preamble describes each characteristic and associated approaches that can be taken to assess and mitigate risks. In addition to information on performance and quality, we also finalize that developers who supply predictive DSIs as part of their products need to apply the risk management practices to their predictive DSIs. We relied heavily on the NISC AI risk management framework, and we emphasize the need for data governance, which we describe as policies and controls related to how data are acquired, managed, and used. Developers are not required to review risk management information for other parties, nor do they have to include risk management information from other parties as part of their documentation requirements. Next slide, please. Some additional clarifications on intervention risk management. The program is not prescriptive about the use of a particular framework or standard or guideline or even best practice for risk management and governance. The program is given substantial flexibility in the risk management practices they choose to apply to predictive DSIs. Developers may choose to apply different levels of rigor to the risk analysis, risk mitigation, and governance. They're not required to review risk management information from other parties, nor include that. in their IRM documentation. Again, back to that concept, we do encourage developers to review the NIST AI RMF Government Section 6, as this section provides several suggested actions and documentation questions that may be informative towards meeting governance requirements as it relates to AI risks and benefits arising from third-party software. Next slide, please. Safety enhanced design and B11 DSI criterion. This is another area in which we've received several JIRA questions on safety enhanced design and how to meet this standard. As you know, B11 DSI criterion is a revision of section 170.315A9, the CDS criterion. Developers may use or resubmit their SED testing from A9 for B11, and that entirely new SED may not necessarily may not be necessary in all circumstances. Certified health IT developers should assess their user-facing functionality gaps and, as necessary, update their SED. Developers will need to publish updated SED information to the chapel to incorporate B11 when seeking certification to B11. Next slide, please. For assurances, maintenance of certification requirements, several source attributes are intended to provide users information on how the intervention performs in local data. This is both because models and data used to drive predictive DSIs will change over time, and because bias and inaccuracies are likely to appear after a predictive algorithm is deployed. If developers do not continue to keep source attribute information up to date, this could have adverse impacts on user trust, accuracy, usage, and safety. This maintenance of certification requires developers to keep such information updated to better maintain the integrity of the decision support interventions. Next slide, please. This is our implementation timeline and requirements. Many of you have probably seen this before. Split up in about 3 sections. The top section is for health IT developers. You'll have a year to update your certified health IT to support the B11 capabilities. You'll need to provide updated technology to your customers by December 31st, 2024, this year. You'll need to provide intervention risk management practice information to your ONC ACB before December 31st of 2024 this year. You'll need to keep source attribute information and risk management information up to date as an ongoing maintenance of certification requirement. You'll also need to include this as part of real-world testing plans and results. There are also implications for providers as of their 2025 performance period for CMS payment policy. Certified health IT will support providers' ability to select both evidence-based and predictive DSIs, as well as access and modify detailed source attribute information for evidence-based and predictive DSIs they use. And of course, we would refer to our CMS colleagues for more information on that. And then the last is the industry, the 31 source attribute fields. Those have been finalized, offers an industry-wide baseline from which more detailed model cards and other industry consensus can be formed. Again, back to that concept of transparency. Transparency provisions are likely to incentivize the creation and support of fair, better validated algorithms in healthcare. Next slide, please. Perfect. And now we're at the Q&A section. I'm looking.
All right. Yeah,
Hey,
so Nikki, hey, this is Jeff. And we have been getting some good questions in the Q&A box. So thanks for everyone for sending information that way. We are going to take the next 10 to 15 minutes to try and work through some of these questions. Please note a couple things. If you'd like to ask a question that we don't get to, please don't ask the question anonymously, and we'll try and get back to you after the fact. And also consistent with previous presentations, we will do our best to publish alongside a recording of this presentation and slides. We will do our best to publish a kind of log of questions and answers. And so with that, I did pull aside a couple questions that I thought we could answer in real time. And then I think our intention was to for those of you who wish to not remain anonymous, we're more than happy to have you ask your questions in real time, I believe. Josh, any other instructions that you want to provide?
Nope, you are absolutely right. We do have one person with a raised hand. So when you're ready to get to the people who are ready to unmute their lines, just let me know and I'll go ahead and do that.
Okay, perfect. All right, so I'd like to take a couple of questions that came in through the Q&A early on where I indicated trying to answer those questions live. This first one comes from Michelle Janowiski, please. The question was, just for clarification, if our evidence-based DSI is tied to a linked referential DSI with bibliographic citations, those do not need to allow for modification. However, if our evidence-based DSI is not linked to a referential DSI, we must allow for modification. Can you confirm that this is an accurate statement? And what I would like to say is that the requirements that we have for modification, which can be found at 170.315 B11 Roman numerat 5, which would be kind of a lowercase v, B1, essentially says that for evidence-based DSIs, the Health IT module must enable a limited set of identified users to record, change, and access source attributes related to that evidence-based DSI. Now, this is true regardless of whether the evidence-based DSI is a linked referential DSI or something that's more kind of traditional, like a translation from a clinical guideline. So, as it relates to this, I would say this is not a correct interpretation. Essentially, regardless of the type of DSI, evidence-based or predictive, users need to have the capability to modify the source attributes, and that is access, record, and change. So I hope that answers your question. Feel free to raise your hand and we might get back to you if that does not. The second question that I'd like to try and answer before going to the virtual crowd here is on supplied by. This questioner was anonymous, but they said that supplied by remains somewhat elusive. During the information session, it was stated that supplied by does not likely include apps available through a certified Health IT developer's app store, but would that not be enabling the technical capability to users? And this is going to be somewhat of a long answer, but just hang with me. So we described two very closely related concepts in the HTI-1 final rule. The first concept is supplied by, and the second concept is, quote, as part of its Health IT module, unquote. So we interpret supplied by to include interventions that are authored or developed by the certified Health IT developer, as well as interventions that are authored or developed by another party that the Health IT developer includes as part of its Health IT module, such as when the certified developer has contracts specifically covering the enablement and use of such technologies. The concept of supplied by means that the certified Health IT developer has taken on stewardship and accountability for that predictive DSI for the purposes of the Health IT module. In other form, we have described this notion, this is not from the HTI-1 final rule, but this is more kind of along the lines of the disclaimer that you saw in the first few slides. In other form, we've described this notion of kind of the press release test. And so if a developer and another party, a third party, or even a client have a press release about how they're integrating this new DSI into their products and it's going to be available to customers, that's supplied by. We're trying to take a fairly literal interpretation here. Now, on the question of included as a part of the Health IT module. So in preamble, we did say that we interpret as part of its Health IT module to mean that the certified Health IT developer has explicitly offered or provided its customers the technical capability to use or support a predictive DSI, regardless of whether the predictive DSI was developed by the certified Health IT developer or another party. So it's really in combination of these two terms, supplied by and as part of the Health IT module, that you come to be able to answer the question of, is this DSI subject to certification program requirements? If the answer is yes to both, then it's subject to both of these it's subject to ONC requirements. So when considering DSIs that are available through a developer's app store, the question is really whether the developer has contracts specifically covering the enablement and use of such technologies, and or whether the developer has taken on stewardship and accountability for the predictive DSI for the purposes of its Health IT module. Those are really questions we can't answer from the outside, and we have a long-standing kind of policy around not rendering judgments on whether a specific technology is or is not evidence-based or predictive DSI. But generally speaking, we tried to establish a requirement so that if the developer of certified Health IT kind of knowingly provides a DSI to its clients, to its customers, that's supplied by. If a certified developer's clients and customers are able to use a DSI and that developer has no idea that that DSI is being used, there's a high likelihood that wouldn't be considered supplied by. Now, again, if there are contractual stipulations in place, then that's likely another set of questions. So I hope that answered, or at least partially answered, those questions. I know that we've got a handful of additional questions coming in through the Q&A, but before we do that, I would invite Josh, do you want to go ahead and invite whoever has their hand up to ask their question in real time?
Sure. First up is Jim Tate.
Great. Thank you so much. Yeah, this is kind of expansion of what you just kind of outlined. So just to be clear, if the certified vendor for B11 is not developing predictive DSIs, they don't have any contractual agreement, there's no stewardship, it's that any third party out there who wants to have a predictive DSI floating in a cloud, a provider, if they're able to figure out how to do it, connect with them and use them, and there are no standards that apply to what happens to that third party out there. Correct?
That generally that is correct. I
Right.
would try and modify the question in one way. When you say standards, I understand you to say kind of ONC requirements.
Correct.
There are no ONC requirements. Yes.
Right. There are no ONC requirements, but they're definitely best practices. But they're even outside of ONC, I'm not aware of any requirements that somebody can't use ChatGPT, which is a worst case scenario. But certainly, there's nothing that ONC says about the quality of that stuff that's out there and the ability
Correct.
of that. Okay, thanks so much. Just wanted clarification.
Yeah, no problem. Yep, no problem. Thank you, Jim. Appreciate that.
That was the only raised hand at this moment.
Okay. Well, there are certainly a number of questions in the Q&A column, as I've got it up on my screen, that we can take a look at. Let's see here. I'm just going to go in terms of what I've got at the top, and we'll try and make our way down through the bottom. So it looks like Kyle Meadows has a question, and you and I have been exchanging some comments through Q&A already. So I'm going to try and answer your follow-up question here. And you say, regarding the answer above on enabling selection, and this question for everybody else is really on the requirements around developers who have to enable selection of a predictive DSI or evidence-based DSI, as is the requirement. So we did not specify a singular mechanism or configuration to enable selection of a predictive DSI that is in the HTI-1 final rule. The question is, can this enablement be done with developer assistance to help the user install, load, activate the DSI, or must this selection mechanism be accomplished without any developer assistance? I would say a couple things here. First of all, the requirement to enable selection is part of the certification to the criterion. So the technology needs to be able to demonstrate how a user might select a predictive DSI as well as an evidence-based DSI. And there are wraparound requirements around specific data elements for both of those DSI types. So that's kind of thing one. There's a basic capability. Can a user select a predictive DSI based on the US CDI data elements? And let's focus on predictive DSIs for now. That's thing one. Thing two is that we did not specify whether or how we did not specify how this selection capability is brought to bear onto the technology. And that's pretty much full stop. We know that there are various ways developers have historically enabled users to select evidence-based DSIs because that's been a requirement for the certification criteria, the CDS certification criterion at A9 for a number of years. Users of modules certified to A9 have to have the ability to select evidence-based DSIs off according to a specific set of data. We're basically just carrying forward that requirement. Now, understanding there's some complexity there for enabling a user to select predictive DSI based off the US CDI. Understanding complexity, we didn't want to be prescriptive about how this is done. So developers have, generally speaking, wide latitude and flexibility to support users in selecting predictive DSIs in a way that they see is most appropriate. I will say in other forum, we've been asked questions around whether a developer must support each and every way a client might want to select a predictive DSI. And we have clarified that no, in fact, a developer is not required to support a 1,000,001 bespoke ways that their clients might want to select a predictive DSI, but a developer is required to have a specific door through which a user can select predictive DSIs, and what that door looks like to perhaps use in precise analogy, what that door looks like is really up to the developers. And we certainly don't really speak to the level of effort that a developer would have to go through, but hopefully that answers your question, Kyle. And again, please raise your hand, and Josh, please cut me off when somebody does. Otherwise, I'll keep going. All right, looking at Bob Bryan asks, is it appropriate for the IRM summary to summarize a general set of IRM practices that apply to all PDSIs they supply, or does the summary need to include more specifics about IRM practices for each PDSI, and should all supplied PDSIs need to be identified in the summary? That is a great question. I might need to follow up, Bob, to get you more specific language. We did address this in the HTI-1 final rule, and based on my recollection, but we can go back and look at this, Nikki, we did not specify that each PDSI have related summary information to it. I think we did kind of discuss this, and where we landed, again, to the best of my recollection, is that a developer that has multiple PDSIs can describe or can summarize their intervention risk management practices generally if the same intervention risk management practices apply generally. So I would say, again, subject to us going back and finding more concrete language, I would say, again, knowing that we have quite a bit of flexibility for developers to kind of craft their IRM summary information however they see fit, I would say generally it would be appropriate to think about your summary information as it applies to kind of specific types of predictive DSI, if that's part of the offering of predictive DSIs. So again, hopefully that answers your question, Nikki. Let's maybe take note of this specific question, and we can try and track down more specific language in the HTI-1 rule.
Got it.
Okay. All right. So an anonymous attendee asked, how often must the info in assurances be updated? Once a quarter, once a month? Is there a set time frame after something changes? Instantaneous for everything that isn't realistic? Question mark. So as it relates to the requirements in the assurances, condition and maintenance of certification requirement, or more accurately, the maintenance of certification requirement, we establish a paradigm that is on an ongoing basis. Developers need to review and update the information as necessary. We don't actually prescribe a specific period or look back. So we don't say every week or every month or every 6 months. But essentially, the notion here is when information related to source attributes, or maybe when a developer changes their intervention risk management practices, it would be then appropriate for that developer to communicate to its users or the public in the case of summary information on IRM practices. It would be appropriate for them to update that information. I think we understand that predictive DSIs in specific are dynamic and they change over time. This could be just through simple versioning. So maybe you've got a predictive DSI and version 1 had a specific set of performance characteristics and quantitative measures of performance. And version 2 has a different set of characteristics and performance levels, and you may want to change that. Or there may be a organizational policy in testing a specific predictive DSI for fairness. And this policy or this approach changes over the course of time. And really the notion here is we put it on the developers to establish whatever cadence of review that they feel is appropriate. We try not to be too prescriptive because we do know that different technology and will evolve at different pace and at different times. So as it relates to this specific question, the answer is we don't have specific periods or cadence of look back, but we do require that when information changes and the developer knows that this information has changed, that they communicate that to their patients, so that their clinical users, so that their users know this information has changed, and to update the source attributes as necessary. Okay, I think we answered Jim's question, so I'm going to go ahead and jump down to Ashley Mann.
Hey, Jeff, just to let you know, it's 3 past the hour. I just want to make you aware of the time.
Oh. Okay. So we're just having so much fun. Let me try and answer this last question, and then Michelle, I see your response there. We've got another anonymous attendee. I'll try and answer this last question, and then we'll close for today. I will underscore a couple of things. The inquiry.healthit.gov is going to be your best way to try and get questions answered. I know many of you have submitted questions already. Thank you for that. It's really what makes these presentations possible and actually somewhat dynamic, because we get inquiries and then we're able to say, okay, actually we're getting a number of inquiries on this line. So please do continue to send your inquiries our way. And also for those of you who have submitted inquiries, thank you for your patience as we do work through some of these fairly interesting questions and some of these not easily answerable questions, but we do appreciate your patience and all that. And then last but not least, Nikki, thank you so much for a great presentation and going through these slides in such detail. So last question of the day from Ashley Mann. What will this look like for real-world testing plan results collection? I don't recall A9 being a real-world testing requirement and cannot picture this. So you are correct that A9 was not part of the real-world testing certification criteria. And because all of the B criteria in the program currently are subject to real-world testing, and B11 is this new criterion, it will be subject to real-world testing. I can't really answer how it's going to look, but I think we did provide some rationale in the HTI-1 I think proposed rule and possibly in the final rule regarding why we thought real-world testing for B11 would be important. And really what it comes down to is this notion that a demonstration of a system's ability to interoperate by taking data from different sources and producing decision support recommendations, outputs is really an important functional demonstration. We, of course, as you know, provide wide flexibility for our developers under the program to create their own measures and to establish real-world testing plans consistent with ways that they would like to highlight the interoperability and capabilities of their systems. So, as far as it goes, there are a number of important requirements within real-world testing plans, including how the module is meeting all of the functional requirements and capabilities outlined in the certification criterion. So I can't give you a concrete answer on that, although I dare say if you thought about how to demonstrate that your system is supporting the B11 criterion and or how your supplied DSIs are impacting patient care, you'd probably be able to come up with a handful of really cool and interesting measures for the public to look at. So with that, thank you very much, everyone. Appreciate the extra time. Sorry for going a little bit over. And please be on the lookout for future installments of our summertime roadshow. Thanks, everyone.